This episode of Transmission Interrupted was recorded August 22nd, 2025. This is Transmission Interrupted, a podcast series from NETEC, the National Emerging Special Pathogens Training and Education Center. Welcome to Transmission Interrupted from NETEC.
Hello, and welcome to Transmission Interrupted. My name is Jill Morgan. I'm a nurse here at Emory University Hospital in Atlanta, Georgia, where I work in our biocontainment unit. For those of you not yet familiar with NETEC, our mission is to set the gold standard for special pathogen preparedness and response across health systems in the U.S. with the goals of driving best practices and closing knowledge gaps, and really developing innovative resources. We hope like this one. NETEC works alongside and in cooperation with the CDC and is funded by ASPR, the Administration for Strategic Preparedness and Response. And today we're going to talk all about respiratory viral season. And welcome to the end of summer when many of us are thinking about, oh gosh, I just heard today, people going back to school, their kids are back in school, and they're suddenly congested and stuffed up and feeling icky. And I thought, well, this is what happens. So we have a lot to talk about today, and I'm really grateful to be joined by three brilliant folks. So let me do some introductions here. We have Dr. Ryan Maves. He is a professor in infectious diseases and critical care medicine, and in the Office of Global Health at Wake Forest University in Winston-Salem, North Carolina. I have Dr. John Horton, who I am going to call Horton, and that is his preference, who's the Vice Chair of Clinical Affairs for Gynecology and Obstetrics at Emory in Atlanta. Dr. Kari Simonson, who's the chair in the Department of Pediatrics and a professor of pediatric infectious diseases at the University of Nebraska Medical Center. So thank you guys so much for being with us. And I am looking forward to hearing more about what you think about respiratory virus season this year. Kari, if you don't mind, let's kick this off with maybe just a little bit of background. When we say respiratory viruses, or if you've ever gone to your doctor's office and they swab the back of your nose or throat and send it off for this panel of pathogens, what are we talking about? Like, what kinds of things qualify? What kinds of things are worrisome? Let's just start with that.
Sure. Thanks, Jill. Thanks for having us on today. Yeah, especially as a pediatrician, the things that kind of come to mind right away probably are those big three respiratory viruses that I think everyone has heard some things about and we'll talk about in depth today, including influenza, RSV, and COVID. And so each of these are pathogens that do now tend to have a seasonality to them, although COVID continues to come in some pretty discrete waves that is crossing seasons. But RSV and flu really tend to be wintertime viruses. And of course, as soon as we all start coming indoors back to school, as Jill mentioned, and spending more of our time in close quarters with one another, that's when we start to see increases in transmission, particularly in kids. So for kids, we're often thinking about the youngest being the most vulnerable. They have the least experience in previously seeing these viruses. And so we are always worried about infants and young toddlers who've not been sick before with these viruses, but certainly they can make kids of all ages severely ill. And so we're always cautious and want to make sure that both families and healthcare settings are prepared for these as we move toward the fall and the winter.
So one thing that I think I didn't know enough about until probably, I'm sure until I was a nurse, and then probably even after I'd been a nurse for a while, is, we think about influenza and many of us just think of it as one thing, but influenza is actually a bunch of things, right? So we have influenza A and influenza B. One of them is much more common than the other, but can you just kind of give us a little bit of information about the differences in influenzas?
Yeah, sure. So we do tend to see both influenza A strains and influenza B strains circulating each year. The A's tend to have a bit more epidemic or pandemic potential than the B strains. They also tend to be a little more genetically variable, so they change quicker year over year. And so in each of our seasonal influenza vaccines, we're always thinking about what do we predict to be the most common strains that are circulating in our communities. And we typically select 2 A's and at least 1 B. So it looks like we'll have a trivalent flu vaccine this fall. But that helps us with best matching what we think are the circulating strains with what people are actually becoming ill with in the community.
Excellent. All right. So that's a good level setting for kind of thinking about these things. And you mentioned the pediatric population and with Horton on, I wanted to ask about pregnant people and really this other fairly high-risk group of people that might be exposed to these respiratory viruses. You might already have kids at home and now be pregnant and be worried about what this is going to bring to you. So Horton, let us hear about what's the biggest impact of respiratory viruses on your patient population and what kinds of things do you try to educate people about these pathogens?
Thank you. I really do think it's important for all pregnant people to know that there are about 4 viruses that we really focus on because those are the 4 that we have vaccines against. The 4 that we really focus on are flu or influenza, COVID-19, and then RSV and pertussis, which we commonly call the whooping cough. Now, the first 2 of those, flu and COVID, are important to know that those both have potential effects to both mom and baby. And so when we diagnose those, when somebody is sick with either flu or COVID and pregnant, we have a heightened sense of making sure that mom is okay. And we might even give medicine to help decrease the effect of those viruses and the effect of the illness on the mother themselves. For RSV and pertussis, they're important that they can make you feel icky. They can give you a cough that could last for weeks sometimes. But these are important to know that we can do something that might help the baby even after delivery. And so we have vaccines for flu and COVID that can be taken at any time and that will help reduce both the impact to the mom and how sick they get. Now, for RSV and for pertussis, or the whooping cough, we time those to be really careful about when we give them. Pertussis has been a standard vaccine for decades and decades. It comes packaged in a group vaccine called Tdap, or tetanus, diphtheria, and pertussis. And so with that vaccine, we can help protect moms and parents from getting pertussis. It's an annoying cough for us as a healthy adult, but if we get it and pass it on to the baby, the neonate can be really susceptible to this, and it can make them really sick. So by preventing us from getting it, we help prevent us passing it on to the baby. Now, RSV and the RSV vaccine is even more special. We tend to give that between 32 weeks and 36 weeks. And by giving this vaccine, we will create the right antibodies, the right immune mechanisms and keys that parents can hand off to the baby even while still pregnant. So after they deliver, they're born with this sense of a protection, a shield that may not prevent them from getting RSV, but it does help them. If they get RSV, it significantly reduces the chance that they would have severe disease and need to be hospitalized. So it really works towards this idea of what can we do in prenatal care to not only help mom's severity of disease, but also to affect the child within and the child after delivery. So it's this holistic view of what does pregnancy mean, not just now, but into the kind of near future. And so all of our docs and our teams and midwives and birthing assistants will really work with moms and birthing parents to understand these 4, especially to see what can we do to make a real difference.
That was a lot that I did not know about. And I wanted to ask you just one follow-on question here, which is about partners and other family members. So, you did a great job of explaining the importance for the pregnant person and, of course, the developing baby and the baby after delivery. But what about the mom's doing everything they could, but maybe they've got kids that are going to school and coming home all snotty, or maybe they have a partner who is working in some other high-risk industry or who is really just bad about respiratory etiquette, and who knows what they're bringing home. We won't even go into that, how bad that might be. But at what point do you worry about the rest of their home environment or their environment?
It's a great question. I get this question from parents routinely, especially when we get into this sniffle season. The important thing to know is that you should feel empowered to control your own home environment. And you should be able to talk with people who are coming into your spaces about, do they have illness? Do they have fevers? Is there something going on? And so you can make sure that you control that atmosphere and let people know that if you're feeling ill, if you're feeling sick, then you should maybe hold off, not come around during that time. And that's okay. Don't feel guilty about that. But also, it is very reasonable to say to those that are around you that if they're going to be taking primary care of an infant, like they're going to be up in the baby's face, changing that diaper and working with that newborn infant, that it's reasonable to ask them, like, hey, it'd be something worth considering, a Tdap vaccine. Have you gotten your the other preventative health measures that can help prevent you from bringing some viruses that might be harmful to a newborn, fresh baby? And so this idea of being open, but not letting it bring you to a point of anxiety, having that conversation should be easy and safe. But the main thing is that you're watching and you're aware of everyone in the household's general health.
That's great. Thank you. I love the phrase of fresh baby. It just sounds so much like, that nice new baby smell. Thanks for that. Dr. Maves, we sort of talked about folks for whom this could have a larger impact and some of the serious things that can come out of these respiratory pathogens. And really, that's where you live every day, right? You are dealing with, in the critical care environment, people for whom whatever plan they had for a respiratory virus, first of all, clearly went wrong that they got one, but now probably took them into an ICU or a CCU or another healthcare environment nobody really wishes to be in. So from your perspective, give us your feelings about respiratory viruses and which are the most sort of impactful, and who does that apply to? Who should be most concerned about these?
Yeah, no, you're absolutely right. Critical illness is clearly obviously a minority of folks who are infected with respiratory viruses, but they're the ones for whom it has the greatest impact. And and unlike Dr. Horton and Dr. Simonson, I am not in the child production nor care industry. I kind of joke. Most of my patients are older adults, and as we all know, the working definition of an older adult is my current age plus 15 years.
I appreciate that personally. Thank you. Yes.
Of course. Yeah. So the people whom we see in the intensive care unit who suffer from the greatest severity of respiratory viral infections are going to be obviously folks who carry a heavy burden of comorbid disease. So particularly chronic lung disease, chronic cardiac disease, patients with underlying both ischemic heart disease and different forms of heart failure. And then some entities that are a little more common. Things we don't necessarily think of as immunocompromising conditions. So poorly controlled diabetes, for example, is in and of itself a form of immunocompromising condition. And those people are people with significant problems with obesity. Those things in and of themselves can be major risk factors for severe respiratory viral infections. In terms of the viruses that are of major risk, influenza, like Dr. Simonson mentioned, is going to be the one on a typical year. Obviously, during the pandemic, COVID overwhelmed everything else. And I remember giving a morning report to our residents back in San Diego in 2021, where I started talking about influenza, and then I paused and I said, for the younger members of the audience, influenza is a largely extinct respiratory virus that we used to worry about a lot. Of course, influenza is clearly back now. Last year was a fairly typical influenza year from a hospitalization and critical care standpoint. There was a bit more than 500,000 hospitalizations in the United States and, around 30,000 deaths. And that's a fairly average influenza season in the United States. With flu, it's not just the respiratory failure that gets you, right? One of the big things with influenza that challenges us is how it can also lead to a kind of hyperinflammatory, hyperthrombotic state. We see that in COVID as well, leading to an increased risk of myocardial infarction, more heart attacks, more strokes. And this has been seen pretty clearly in the vaccine literature, that folks at risk for heart attack and stroke, getting an influenza vaccine every year reduces the risk of heart attack and stroke. That's beyond the strict benefits of not getting sick with influenza. The other viruses we worry about are, just like Dr. Simonson and Dr. Horton mentioned, RSV as a cause of adult respiratory disease is really something we've only recognized for the last 12 plus years. And I think we all had historically thought of this as a disease of childhood. And then once the availability of rapid and accurate PCR testing for respiratory viruses in adults became available, all of a sudden we find all these old folks with emphysema who suddenly, it turns out they had RSV the whole time, and that's what was driving their COPD exacerbation or what have you. In terms of the syndromes we see with folks, older folks with RSV compared with influenza, they overlap a great deal. There is an interesting epidemiological relationship between RSV infection and decompensated heart failure, though. And even though that's just observational data, it's very replicable. And this has changed a little bit of the approach I think a lot of us who care for folks with chronic heart disease take towards RSV vaccination. That actually one of the first groups at my hospital who got very engaged and very proactive in getting their patients vaccinated against RSV when the 2 or 3 now licensed RSV vaccines for adults came on the market were the heart failure cardiologists, were the people evaluating patients for consideration of either chronic heart failure, advanced therapies, or potentially transplant. And they were the ones who really led the way for a lot of us. And then the other one is, of course, COVID-19. Obviously, the extent of when you look at the numbers of hospitalizations and mortality now, it's a little more on the level of influenza. In the last year, the number of influenza deaths and the number of COVID deaths were about the same. And you can say, okay, great, that's wonderful. But now we have 2 separate flu seasons, right? Or now we effectively have 2 flu seasons with COVID on top of influenza. And the seasonality of COVID doesn't seem like it's quite the same as influenza. Clearly, there is a wintertime spike. But right now, we're having a little mini summer spike. I admitted my first old-fashioned COVID respiratory failure patient last week. Now that person is doing considerably better than comparable patients in 2020 and 2021, but it remains a major threat. After that, then we have a number of other, we'll call less frequent respiratory viruses that have similar severity. Human metapneumovirus in adults causes a disease that is very similar. It's biologically fairly closely related to RSV. Causes a syndrome that's actually quite similar to the syndrome of influenza, even including the risk of staphylococcal superinfection. Staph pneumonia, community-acquired staph pneumonia is relatively uncommon in the absence of preceding influenza or metapneumovirus. And then in high-risk folks and people who are significantly immunocompromised, hematologic malignancies like leukemia, recently following a solid organ transplant or after a bone marrow transplant, it can be any virus. I've actually been seeing a patient today who I think is on the ventilator just from old-fashioned rhinovirus.
Wow.
And has just, extremely severe lung disease. And so it doesn't take much. And that's probably the take-home lesson, is that with a lot of the strategies that all of us are talking about, they're not, if you get to me, then something has gone horribly wrong in your life. And the fact that the 3 of our
at least
practices,
professionally.
Exactly. That, the rest of it is kind of up to you, I guess. But, if the fact that Dr. Horton and my patient populations rarely overlap is a good thing for the human race, right?
Absolutely.
And in terms of finding ways to minimize that risk, not just for yourself in terms of acquiring respiratory viruses for your own health and well-being, but recognizing that we are all exposed to people at greater risk. And those things at greater risk are not necessarily visible, right? That even if we think, well, I'm only really around healthy people, well, pregnancy is an immunocompromising condition. And I would say a solid 80% of us are related to someone who's been pregnant at some point, if not more.
I think it's so interesting. I'm glad you mentioned RSV, and I felt like I might have just missed a chapter or something, because it seemed to me in my medical ICU days that really in adults, and I was only dealing with adults in the intensive care, was that it really was in, as you said, sort of organ transplant, a whole transplant community. We had to worry about RSV, but not so much in the rest of the adults. So I wonder now, as you mentioned this link with RSV and heart failure, I wonder if you could kind of give us any clues, and I would be open to anybody answering this, but are there different symptoms? If somebody has a fever and some sort of respiratory symptom, is there something that tells them that this might be RSV versus influenza or versus, something else? I do think that typically for us, we think about rhinoviruses not causing a fever and maybe the rest of them do. But besides that, how would anybody know without that annoying swab in the back of their nose?
Well, I would start off, I guess, by saying you're right. We know more because we test more than what we used to have the capability to do. And I think that in some respects, then that also gives us a healthy understanding of how much overlap there is between these viruses and the syndromes that they cause clinically. So I would say there's maybe some clues at times in what differentiates RSV from influenza or COVID in children, but the overlap is significant. So it's much more reliable to really go ahead and do a nasal swab and find out what virus you're dealing with, particularly in things like thinking about what will you do next when we have specific antivirals or other treatments, and our strategy may differ if we do have a diagnosis. So I think it really does behoove us when the setting allows it to go ahead and do respiratory sampling to find out what virus is there, because there's a lot of overlap in what you'll see clinically.
I would also say to just everyone be mindful of how available testing is, but getting tested is the first kind of step. And it may be a home test. It may be going to an immediate care center. It may be calling your physician or APP, advanced practice provider, to get tested at a larger lab. But know that there are many ways of getting tested, and the availability is really high right now, which is amazing because we haven't historically always had this ability to test at home or access very quickly. If you're in a rural area and you don't have quick access to your care team immediately, then it may be worth having around some home testing that you can test if you need, for both convenience and understand what next steps you might want to take or when to call your providers.
Yeah. And so you're really saying that you should test, like, specifically, you have some symptoms of an upper respiratory kind of thing. So whether that's a cough, sore throat, that kind of snottiness, and a fever, right? Or do you not have to have a fever? What is the rule of thumb there?
I don't think there's particularly rule of thumb. The presence or absence of fever is going to vary somewhat by population. For example, in pregnancy, straight up septic shock in pregnancy is only associated with fever half the time.
Wow.
Older folks are less likely to mount a fever, and fever is not necessarily a continuous thing throughout the day. It comes, it goes, and there's a little bit of
Sure.
a artifact of the timing of testing that affects the presence or absence of fever. Certainly, it's interesting to know, and the presence of a fever is certainly suggestive, but fever is also an adaptive response. If you have an infection and you're febrile, that is a normal, conserved evolutionary response that we are supposed to have. It is not pathologic per se. Recognizing, obviously,
Right.
in very young children, febrile seizures are a concern, and they're not entirely benign. Syndromically, in adults, respiratory viruses are basically indistinguishable from one another. And in the absence of testing, it can be very hard to figure out which one is which, just like Dr. Horton and Dr. Simonson were saying. I would say that some of the home tests are not as sensitive as the nucleic acid-based tests. So the multiplex PCR that I order in the hospital, covers a wide variety of respiratory viruses and is very sensitive. In some cases, perhaps a little too sensitive. It may be detecting a virus you had 2 weeks ago. The rapid antigen tests that you can get both in healthcare facilities and now increasingly at home, like Dr. Horton was saying, those are good tests, and the positive predictive value is pretty good, right? Like if it's positive, it's probably really positive. But they are not as sensitive as the molecular tests. And you just have to be aware of that the rapid flu tests, for example, are like 50 to 60% sensitive. Some of that is operator driven. Some of that is just a limitation of the assay. And it's worth being aware of. There are also some narrower spectrum tests, often like our emergency department will run, that only cover flu, COVID, and RSV. And that's really just looking at what are the ones we can do something about, right? Because if someone has a positive rhinovirus test, unless Dr. Simonson was at Pleconaril is back on the market now, which I doubt, there's nothing I can do about rhinovirus or an enterovirus.
Yeah, drugs that never made it. Great
Never
ideas,
made it.
though.
Yeah, I know. Oh well, dare to dream.
So it sounds like we really need sort of a misery index, right? Like At what point do I decide to be tested? When I feel like there must be something worse going on. Or if I'm paraphrasing y'all correctly, if I'm going to be around people I really don't want to make sick, whether that's my grandparents, somebody's kids, somebody pregnant, if I'm going to be in a really crowded environment where I might be like influencing the entire plane of people going on vacation, please don't do that to somebody else. If you feel badly, test. What else do we want to say about that before we talk more about vaccinations?
Right. I would also just come into be mindful of chalking things up to allergies, especially if all of a sudden you're in a situation or a season for which you don't normally have allergies. You're like, oh, it's just my sinuses, or it's just a drip. If it seems different, like ask yourself, is this different than my usual?
Yeah, we do not want to inadvertently or like, I don't want to be sick, therefore I'm not going to believe that this is actually something. I'm going to attribute it to allergies when it's not. Yeah, I totally get that. So thank you guys for that great perspective and really thinking about how bad these things can be for some people and at what points they can be so bad. And I want to look forward, if we can, to this upcoming respiratory virus season, even though we're going to say COVID doesn't have as much seasonality perhaps as our influenzas do. I want to peer into our magical crystal ball and say, what do we think it's going to be like this year? I mean, I know part of this is Kari, you said we base our upcoming vaccines on what we've seen around the world. I mean, in some ways, we're lucky that the folks in the Southern Hemisphere sort of give us a preview to some extent of what flu season might look like, what to mix into the potion to give people the best chances for some immunity to these things. But does anybody have a prediction for what things are going to look like this year, both in terms of what we might see with respiratory viruses and what we might have available to us? You know, there's a lot of stuff in the news lately that we're not going to talk about today about vaccinations and the availability of vaccines, but I just would like to get y'all's perspectives on where you think this might go this year. And Kara, I'm going to start with you because I think you sort of keep your fingers on the pulse of an awful lot of this.
Well, thanks. I'll do what I can, and then I look forward to others' responses too. So, in thinking about what we're planning for the flu vaccination campaign for the fall, the upcoming flu vaccine will be trivalent with the influenza A components being H3N2. That's a new component. And then H1N1, that will continue, same component as in last year's vaccine. And then the B Victoria lineage components are unchanged. So we really only tweaked one strain that's in our planned fall flu vaccine. So that to me speaks to a sense of maybe what happened last season. We'll still see some circulation of similar strains. And although last season was actually quite severe as far as a non-kind of pandemic influenza season, perhaps this upcoming one may not be quite as severe because we'll have some similar strains circulating. A number of folks will have some prior exposure or previous immunity that might help mitigate some of that severity. But again, this is crystal ball, so don't hold me to it, but I guess I'll start there.
Yeah, thanks. I promise to not have you all back in February to take your words back. I completely get that this is not a real crystal ball. Dr. Maves, give us your best guess.
I am going to predict average flu season. I think for much the same reasons that Dr. Simonson described, that barring some unexpected change in circulating influenza types, I think it's going to be pretty average. But again, reminding everyone that pretty average includes now COVID on top of influenza. So I think the overall burden is going to be relatively high. And I somewhat sarcastically refer to flu season as the happiest time of year in the ICU. It's going to get busy, and I'm hopeful that I'm wrong.
Yeah, well, we appreciate that. All right, Horton, what do you think?
I do have actually great hope for this season, and part of the reason is a continued stream of really impressive and amazing safety data on pregnant parents, pregnant mothers who get vaccines and have very low effects from them. And so we're really seeing more and more traction on the just normality of getting a vaccine to help prevent severe disease in themselves and in their newborn children. And so I have actually really hope that it will be hopefully a mild vaccine season, but that we will help make not only the numbers of how many are getting it somewhat diminished by the severity, but with hope that we really work on vaccination, especially up in my population that I see with pregnant parents and mothers, that we can get vaccines for COVID and influenza and our standard vaccines of Tdap and really work during this season or those 32 to 36 weekers for RSV vaccines to really protect the newborn children that are even born just after the season.
Excellent. All right. So far, and I know we're going to try to wrap things up here, but so far, what we've been talking about as an intervention has been largely vaccination. And anybody who's listened to the podcast before knows that, I am a big fan of PPE. And so I just want to spend just a couple minutes here at the end talking about some other things people can do to help themselves stay safe. So obviously, we do believe in the value of vaccination to decrease morbidity and mortality, to decrease our likelihood of spreading it to other people, and to the ability to incur some safety and protection to newborns. But source control works to help reduce the amount of stuff that we exhale into the environment around us. Really important to think about as the weather gets cold and you can see somebody's breath. I want you to think, the first time you see that this year, I want you to think, ooh, that's what I breathe in when I'm too close to somebody. Is that whole little cloud of it. So source control works. So wearing a mask really does help decrease infection. But if you're a healthcare worker, I want you to go beyond a mask. Because in order to really protect our respiratory tracts, and Dr. Mays, I know that you probably preach this a lot in the ICU, but that in order to protect ourselves from respiratory pathogens, we have to wear a respirator. So that's an N95 or equivalent respiratory protection. Hand hygiene, good grief. The lesson we want to teach everybody, wash your hands. Keep your hands off your face. Don't touch your face. Blah. And I think respiratory etiquette. One of the things I loved about COVID was this whole idea of, what was that thing people did? What is that DAP thing where they cough into their elbow? I don't know how to do that. I'm way too old to be cool, but that kind of thing, right? Don't cough into your hands, then touch stuff. Blah. So anything else that y'all want to mention about ways that people can help keep themselves safe?
Well, everything I ever needed to know, I learned in kindergarten, right? Cover your cough, don't sneeze on other people. And I think importantly to stay home if you're sick. So continuing in a healthcare setting to make sure that we mitigate presenteeism, make sure that we have a culture in our healthcare environments that says, if you are sick, stay home, keep your symptoms at home, don't make others sick. So I'll just add that.
That's fantastic. Yes, thank you for that.
As I look at Dr. Horton and I see his procedural goggles, that was actually a thing I was thinking about as well. I'll admit that when I was doing procedures in the ICU pre-pandemic, I was a little sloppy about eye protection, right? Because, you just come in and intubate someone, or when I'm placing a line or something like that. And now I have procedure glasses that I carry with me in the unit and use specifically for procedures, separate from my regular glasses, because they wrap around and they look cool, and there's no hipster like an aging hipster. So, but the role of eye protection, and there was some interesting, observational papers during the pandemic about how people who wore glasses were at lower risk for respiratory infections, and the role of conjunctival surfaces and conjunctival mucosa as a mechanism for respiratory virus transmission. So, yeah.
Yes, absolutely. And Horton, I'm going to give you the last word, but I want to mention here, love to read literature and papers about these kinds of things. And a study I read, I just loved because it's very difficult to decide, as Dr. Mayers was saying, like, was my exposure into my eyes or was it into my nose or mouth? Because it's hard to separate those things. And animal research is not always kind, but I love this study with ferrets where they actually fit the ferrets with these little like swim goggles, right? So the tiny little swim goggles on ferrets, where what they did was just basically pipe in flu virus to just the surface of their eye, right? So they could separate it from the nose and mouth. And sure enough, as you said, when we teach people now about the importance of eye protection, I tell them, that little lacrimal duct, those tear ducts they slip and slide entrance to our respiratory tract. And so it goes into our eyes and goes right back to the back of our throat and there, takes off. So absolutely. I think face shields became much more common during COVID. And I think it's been a great improvement in reducing things that are a splash, spray, or even just a contact with our eyeballs. So not a substitute for respiratory or mask, but definitely a good value add. All right, Horton, give me your ideas of important things for people to do to protect themselves.
I think just having a self-awareness. Are you sick? Are those around you that are sick? And feeling really comfortable to say, hey, look, I'm gonna stand this one out. I'm not feeling well. I could wear a mask, or maybe I should work from home, or maybe I should take the day off. I think Kari really said it best, of having a self-awareness of, am I ill, and not feeling that need to have to push through. I know we all have this real drive to make sure we're there, especially as healthcare workers, for others. But if we show up and we make others ill, we just make everybody else's day much more challenging down the road. And so I think you've said it best of, wash your hands. If you're sick and can't stay home, do. If you have to get out, wear a mask to help protect other people you may have. And just think about what are the other things that you could do in a day-to-day life, making sure both you and your loved ones have your vaccines, and just try to do your best. And that's all we can do.
Such a nice message to end on, that we should all just try to do our best. I feel like, like Kari said, it's really going back to those lessons of our kindergarten days. I can just imagine Mr. Rogers saying the best, you just have to do your best if you can. I think, as we mentioned at the very start, we're about to kick off respiratory virus season. We know that when people go back to school and as we said, are in closer proximity and closed environments. So the other things that people can do to reduce their exposure to respiratory viruses is to get more fresh air and let more fresh air into your homes. If that's possible for you, we understand that that's not always easy. I don't want anybody to swelter. It's still very hot in much of the country. But certainly as we get into the cooler weather, dilution is a positive effect too. So think about wearing a mask. Think about getting vaccinated when you have those things available to you. If you're pregnant or thinking about becoming pregnant or have a newborn at home, make sure you talk about vaccination with your care providers. And for those kids going back to school and in school, really be on the lookout for early symptoms that may or may not include fever, but making sure that we're not sending kids to school to make other kids sick. Because some of those, as we've said today, you never know what somebody else is going through or what somebody else has at home. And that might be that they have some other issue that makes them higher risk for a pathogen that may not make us very sick at all. So I think those are just really great messages to take out of today's session. And I want to thank you guys so much. This was a lot of fun. I learned something every single time I do this. And it's such a pleasure to talk with people who know so much about a topic that a lot of people know a little bit about and not many people know a lot about. So I am very, very grateful. For those of you listening at home, thank you for tuning into this episode on respiratory virus season. We hope you'll join us for future episodes on all kinds of topics. Healthcare worker safety and personal protective equipment, my favorite, to all kinds of infectious diseases and how to prevent them. If you have questions, ideas for future shows, anything you'd like to know about these topics, please feel free to contact us at info@netec.org. That's info@netec.org. You can also find us on the web at netec.org/podcast, where you can also subscribe to future episodes and find more information on today's topic, including a couple websites that will help you, if you are a flu nerd, kind of track the flu that's going around our country and the world. So thank you again to my guests, and we'll see you next time on Transmission Interrupted.
You've been listening to Transmission Interrupted, a NETEC podcast, produced and edited by Benjamin Madsen, with additional support provided by Britton Clark, Veronica Lavaro, Jason Noble, and Lisa Stone. Special thanks to our guests and the subject matter experts at NETEC for their insight and guidance. This podcast is supported by the Administration for Strategic Preparedness and Response. For more information, tools, and training on special pathogen preparedness, visit netec.org. And don't forget to subscribe, rate, and share the show on Apple Podcasts, Spotify, or wherever you get your podcasts. Thank you for tuning in to Transmission Interrupted.